And there is our recording. So we would ask, because it is recorded, that you refrain from using any personal health information in your discussions and in the chat. And then if you have any questions or concerns regarding privacy or any questions at all before, after, follow-up items, please email Ann Goodman. And that email is provided in the chat. It's basically a.goodman@hemophiliafed.org. But again, that's in the chat, as is everything. So in terms of how the flow of the session will go, you'll notice that basically each session will follow the same structure. We'll do a brief introduction. We'll then have a presentation by our guest speaker, again, Dr. Nancy Sakari today. And then we'll have an interactive case-based discussion. And again, that's where we really would love for you to be very engaged with us, either in chat, turn on your video. We would love to see your faces if you're comfortable. Totally understand we're all busy and you may be quickly trying to have lunch or breakfast, depending on where you are. But if you can, we'd love to see you on video. And then we'll have a brief session wrap up. Again, one of the key things is really having it interactive. So we really encourage you to engage with us. So it's also important to know that we are looking for cases, whether they're cases of patients that you've previously taken care of, or kind of hypothetical cases that are similar to what you've seen. Submitting those in the chat, both now and for future cases, we're definitely looking for. And again, you can share that, especially for future cases, at that email address. And so with that, I wanted to begin this series. So this will be a series of 4 sessions. This is one of 4 between August and November of this year. And again, this specific topic today starts with how to approach and screen women with heavy menstrual bleeding for potential bleeding disorder. And our hope is that we'll cover kind of a broad range of topics for you, including the actual specific evaluation of women with a bleeding disorder, thinking about iron deficiency in terms of evaluation and treatment. And so there'll be a number of series over the course of the fall. And although it's certainly not a requirement that you attend all the sessions, we definitely encourage you to consider them, because they really complement each other and really give you the breadth of, what we're hoping for you to be able to take home to your patients when you're thinking about heavy menstrual bleeding and potential bleeding disorders. Any questions or comments or anything that's not working before we get started? Okay.
I love you putting who they are and where they're from in the chat. This is awesome. From
That's great.
Minnesota, Oregon.
And it looks like we have, some patient experiences, providers, which is great. I'm going to go ahead now and share my screen so we can get started with the presentation. And you can see first, take a moment to basically review our disclosures. This is basically an important for you to be aware of the nature of the relationships of those who are involved in this presentation and any disclosures that they have. And with that, I would like to go ahead and introduce you to our today's guest speaker. We are honored today to have Dr. Nancy Sakari with us. Dr. Nancy Sakari is a fellowship-trained pediatric and adolescent gynecologist. She is the director of pediatric and adolescent gynecology at Emory University School of Medicine and Children's Healthcare of Atlanta. She served as the chair for the North American Society for Pediatric and Adolescent Gynecology's 2022 annual clinical and research meeting, and continues to be an active member of both the Education Committee and the Anti-Racism Task Force. She has served on the American College of Obstetricians and Gynecologists Adolescent Committee, and is currently serving on the Clinical Consensus Committee for Gynecology. Dr. Nancy Sakari is actively developing documents with the Foundation of Women and Girls with Blood Disorders regular gender-inclusive hormonal therapy guidelines. And with that, I would like to turn the talk over to Dr. Nancy Sakari. And we will begin with a pre-session poll. So you'll see here, and I'll let her take over at this point.
So we're going to ask you guys to answer these questions. You should be able to do it on the screen in front of you. If you have any issues, please reach out to the IT people listed in the chat, and then the questions will be repeated at the end. So we'll give you a few minutes to go through that.
So you can see the first question is, what is the definition of heavy menstrual bleeding? And we want you to select all correct options. And Whitney, can you see, are the participants able to click? I don't see their results.
I don't see any responses yet. Does everybody see the poll? You can let us know in the chat if there's a problem.
The
I
chat
can
link.
see it, but I can't seem to actually click on the boxes.
Oh no.
Whitney, is the link in the chat?
It should have popped up on the screen. Let's try. I'm going to relaunch. Let's see if that works. And then maybe we'll try something else for the post poll if it's still not working.
Yeah,
No, it works now.
It does? Okay.
and then I think that we're going to actually show it with the responses with the post-session poll.
Great. So question number 2 then. What are 2 non-gynecologic risk factors that would raise the index of suspicion for an underlying bleeding disorder? And again, and here we want you, it's multiple choice. You want to select all correct answers, maybe more than one. There we go. Looks like easy bruising, bleeding from trivial wounds. One person added dark circles under the eyes. Looks like we have a few answers here. Nosebleeds. So something to kind of think about that we'll delve into with our lecture. So question number 3, those with bleeding disorders make up what % of the general population, but what % of adolescents with heavy menstrual bleeding will be diagnosed with a bleeding disorder? It's like the most popular is about 1 to 2% of the general population, but about 20 to 30% of adolescents, versus a little higher proportion potentially. And then the final question, according to the American College of Obstetricians and Gynecologists, a bleeding disorder workup is warranted for an adolescent female with heavy menstrual bleeding for any one of the following criteria, except what is not a criteria. It looks like bruising 1 to 2 times per month maybe is not a criteria. It looks like the most popular. Also potentially history of anemia or family history. So hopefully Dr. Sakari can now enlighten us on some of the true answers to these questions. So with that, Whitney, I'll go ahead and end the poll so we can proceed. Is that okay with you? Right. So with that, I will let Dr. Nancy Sakari go ahead.
All right. So I think you guys actually did quite well with the pre-session poll. Today, we're going to talk about how do I screen for a bleeding disorder, specifically in women and adolescents with heavy menstrual bleeding. And then based on that information, the next session will be about what you actually do, like laboratory evaluation, to evaluate for a bleeding disorder. So our learning objectives today are to recognize and identify the common signs and symptoms that raise the index of suspicion of an inherited bleeding disorder in women and adolescents, sharing information with patients regarding when bleeding may be considered abnormal and warrants further investigation. And then I'll give you guys a couple of resources and tools to screen for bleeding disorders. So bleeding disorders are not uncommon, and certainly among women with heavy menstrual bleeding, we'll go on to talk about how they're actually relatively common. They are definitely underdiagnosed. There's an average of 16 years between the onset of symptoms and the diagnosis of von Willebrand's disease specifically, which is the most common bleeding disorder. And this lack or delay in diagnosis has a lot of implications. So for one, if we don't know about the bleeding disorder, then we can't treat them currently. So if they're experiencing heavy menstrual bleeding and they're diagnosed with a bleeding disorder, we can be a little bit more specific about how we're treating them, how we're managing their menses, making sure they're not getting anemic and repeat transfusions. But it also helps for future planning. So if they need dental procedures, surgery, pregnancy-related bleeding, there's a lot of things that can be done prophylactically if we know somebody has a bleeding disorder. And then also, if there's like trauma or emergent surgery, the patients can wear medical ID bracelets that will also clue in medical providers that they have a bleeding disorder. So there's a lot of catastrophic events that can be prophylactically prevented if we know a patient has a bleeding disorder. So first, we're just going to define what's normal. So this slide goes into the average age and normal length of everything. So the average age of menarche in the US is between 12 and 13. It usually occurs about 2 to 3 years after breast development starts, or Tanner stage 4. 98% of American girls will have had their first period by age 15. Now, they can be irregular for 3 to 6 years after menarche. We usually say 2 to 3 years when we're evaluating for irregularity due to anovulation in this anovulation due to immature HPO access. The mean cycle length is 32 days in their first gynecologic year, but anywhere between 21 and 45 is going to be considered normal. Less than 7 days of flow and 3 to 6 pads per day. Heavy menstrual bleeding in the adolescent is defined as excessive menstrual blood loss that interferes with physical, emotional, social, or material quality of life. And I think of it as the rule of 8. So greater than 80 milliliters of blood loss a day, which no patient is going to tell you, with the exception that I will say now with some of the menstrual cups and new menstrual products, they do tell you a little bit more specifically about milliliters of blood loss. 8 or more days of bleeding, 8 or more pads per day, or using more than 1 pad per hour for multiple hours. And I really like that specifies multiple hours, or more than 7 pads per day for multiple days. Repetitive passage of blood clots and flooding or doubling up on the pad, again, for the majority of their cycle and for the majority of cycles. The differential diagnosis for heavy menstrual bleeding in the adolescent, and we'll talk about the adult as well, is really pretty broad. You can see here, anovulatory bleeding under endocrine is probably going to be the most common. We're certainly seeing more and more PCOS with the rise of obesity in the adolescent. Other causes include pregnancy-related bleeding, infections, so evaluating for sexual activity. Uterine or structural causes like myomas and polyps are less common in the adolescent population, but certainly very common in the adult population. Medications can also lead to irregular bleeding, or if they're on anticoagulants, heavy bleeding, and then, trauma, some type of laceration, of course. What we're going to be focusing on is bleeding disorders. There are a lot of bleeding disorders, von Willebrand's disease being the most common, but also including thrombocytopenia, platelet function defects, and clotting factor deficiencies. So this is from ACOG Palm Coin in the evaluation of women with abnormal uterine bleeding. And generally speaking, the palm or structural causes we see more commonly in the adult population, like polyps and fibroids. And the coagulation, ovulatory dysfunction we see more often in the younger populations, but things like coagulation obviously will carry into adulthood. So those of you that said 1 to 2% of the general population is affected by a bleeding disorder were correct. The prevalence of bleeding disorders in women with heavy menstrual bleeding, though, is far higher. So somewhere between 5 and 20% of women with heavy menstrual bleeding have von Willebrand's disease. And what you can see, especially with platelet dysfunction, this is a really broad range. I get that, less than 1 to 47%. And this reflects two things. So for one, it reflects where the studies are done. If they're done in like a hemophilia treatment center or a hematology clinic, obviously that prevalence is going to be much higher. Whereas if it's done in like a family practice office or just an OB/GYN clinic, the prevalence is probably going to be at the lower end of these ranges. With platelet dysfunction specifically, they'll get into this more next time, but they're incredibly hard to diagnose because of difficulty with interpretation. They need to be done under certain settings, transported to very specific places that can actually run those labs. So they're just more difficult to diagnose. There was a large prospective study done by Zia et al. Relatively recently that found bleeding disorders among adolescents to be 33%, with heavy menstrual bleeding, sorry, to be 33%. The vast majority were either low von Willebrand's factor, so von Willebrand's factor between 30 and 50, or truly von Willebrand's disease. This study was not powered to elicit risk factors, but they did have they did find a higher risk of bleeding disorders among younger age at first bleeding event, which makes sense, right? If you have a bleeding disorder, you probably have it from birth, so you're going to have heavy menstrual bleeding from menarche, and interestingly, Hispanic race. So the prevalence of heavy menstrual bleeding, when you look at people that have been diagnosed with bleeding disorders, is really pretty profound. So up to 100% of women with von Willebrand's disease report heavy menstrual bleeding. And you can see with Glanzmann thrombocythemia, that rate is also really high. This study looked specifically at women with von Willebrand's disease, and you can see of the bleeding symptoms that heavy menstrual bleeding was the most common reported symptom. So who warrants further evaluation? We're going to talk a lot about history and how to utilize history to decide which women and adolescents will go on to require testing. So the history, we'll start with the bleeding pattern, which I think you guys are all probably very good at doing. And we already talked about, you know, how often they bleed, for how long, and how many pads per days with soiling or clotting. Any symptoms or history of anemia, and then evaluating their sexual and reproductive health, for one, to know whether or not we should be including cervicitis or infections or pregnancy-related bleeding in our differential, but it'll also help us when we're talking about different treatment options. And any other associated symptoms, anything that might be suggestive of underlying endocrinopathy, chronic medical illnesses, again, that will help us guide treatment, but also would be important to know if they already know they have a bleeding disorder. But additionally, if they have some kind of medical comorbidity that requires them to take aspirin or some type of anticoagulation, and then actually eliciting for the medications that they take. Finally, family history, not just if coagulopathies are obviously very important to help guide therapy, but also if there's a family history of bleeding disorders, but also very importantly, if there's a family history of heavy bleeding or need for transfusions, because it's possible that their mom just has an undiagnosed bleeding disorder, and that can often be elicited by asking if their mom needed a transfusion with deliveries or had heavy menstrual bleeding. So these are some red flags that I think are pretty obvious. Prolonged bleeding from trivial wounds. We'll talk a little bit more about heavy, prolonged, recurrent bleeding with surgery, dental procedures, trauma, prolonged nosebleeds, unexplained bleeding from the GI tract, anemia requiring iron therapy or transfusion, heavy menstrual bleeding and family history, as we previously discussed, in postpartum hemorrhage. So all of these are kind of red flags, but actually quantifying how risky they are, or based on this history, who should actually get a bleeding disorder assessment is better defined by bleeding assessment tools. So validated bleeding assessment tools are recommended for patients presenting to primary care settings, so like a OB/GYN or family practice setting, and reporting heavy menstrual bleeding. They are not recommended for like hematology or specialized treatment centers. So the International Society for Thrombosis and Hemostasis has a bleeding assessment tool, and this is a great organization that, you know, when we're talking about hemostasis and heavy bleeding, that's our go-to for references. Their bleeding assessment tool included 14 variables. The score of each was between 0 and 4, and a total of greater than 5 was considered abnormal for adult women. But the sensitivity and specificity really vary depending on the population. Specifically, it was less sensitive for adolescents, males versus females. But I would say that the biggest problem with this is that it's 14 variables with a score of 0 to 4. So we know you guys are all busy providing, nobody has time for that. So we looked at a lot of other bleeding assessment tools. This next one, by Philip et al., I found really helpful in kind of getting us to where ACOG got. So they actually administered a 12-page questionnaire on bleeding symptoms, and they narrowed it down to 8 questions, and generally speaking, 4 categories for people that should go on to be assessed for a bleeding disorder. So if you go to the next slide, we have those 4. So this was an 82% sensitivity for bleeding disorders if positive, and that was increased to above 90% with use of what we call a PVAC score, which I'll show you in a couple of slides for now. Now, what you have to keep in mind is that they were looking for a screening tool. So the specificity of this was far lower depending on the population, but they found that if people complained of greater than 8 days of bleeding and flooding or impairment of daily activities with most menses, or a history of anemia, a family history of a diagnosed bleeding disorder, or excessive bleeding with tooth extraction, delivery, miscarriage, or surgery, those patients should go on to get a evaluation for a bleeding disorder. So based on kind of the previous bleeding assessment tools and some others, ACOG recommends this, which is kind of our simplified, this is your money shot, your take-home message for heavy menstrual bleeding in the adult female population. So heavy menstrual bleeding since menarche, in addition to either a postpartum hemorrhage, surgery-related bleeding, or bleeding associated with dental work, or 2 or more of the following: bruising 1 to 2 times per month that is not otherwise explained, bloody noses 1 to 2 times per month, frequent gum bleeding, and family history of bleeding symptoms. This is from the ACOG document on heavy menstrual bleeding in the adolescent, and what you're going to find is there's a little bit of a lower threshold to go on to do a bleeding disorder assessment in the adolescent with heavy menstrual bleeding, because of course they're closer to menarche, so they're more likely to have had heavy menstrual bleeding since menarche. So again, the duration of menses greater than or equal to 7 days, and women reported either flooding bleeding through a tampon or napkin in 2 hours or less with most periods. Again, this cannot just be like part of 1 day, most days of most periods. Again, a history of anemia, a family history of a diagnosed bleeding disorder, or a history of excessive bleeding with tooth extraction, delivery, miscarriage, or surgery. Yeah, okay. And then this is what I was alluding to earlier. This is the pictorial bleeding assessment chart. A score of greater than 100 is supposed to be associated with the 80 milliliters of blood loss. That it has not been entirely reproducible, but it can still be a valuable tool. So what you can see is that the column has the score of each, what I'll call saturation level. So the next column over, that's labeled towels. I don't know, Tricia, if you want to show them. I'm doing it over here with my pointer. I have been the whole talk knowing that you guys can't actually see what I'm doing. Yeah, there you go. So you can see the one that Tricia or Dr. Hughley is pointing to, that would be worth 20 points. And then if you go across the row at the top labeled 1, 2, 3, 4, 5, 6, 7, 8, that's the day of the period. And so your patient would simply go in and mark the number of each kind of saturation for either pad or tampon based on that day. So this particular patient had a total pictorial bleeding assessment score of 320. So that would definitely be greater than 80 milliliters of blood loss. This is kind of the most objective, the way of collecting the most objective data, but it's not great for like retrospective information, simply because nobody's going to really remember that. But it can be helpful prospectively, and it can be really helpful if you have a patient that's difficult to control, to really help monitor the response to various therapy. So that is who you should send on to get a laboratory evaluation. And the next echo series will include what should actually be done in that laboratory evaluation. So please stay tuned for that. Now we're going to do the post-session poll. So please select the definition of heavy menstrual bleeding, all that are correct. And I can't actually see when people respond or who is.
We don't have any responses yet. Can anybody let us know in the chat? Oh, no, there's one. Okay, so it is working. And I will share the responses after a couple of minutes, and then we should all be able to see what scores people got. So we're at 4 people so far. I think we'll give it just another minute if that's all right. All right, I think we'll just give it a few more seconds. Last minute responses. All right, and I'll go ahead and share now. Oh, it says it failed.
Oh, I can see it. I can see it. This is good.
Okay.
So yes, the menstrual flow, that first one is incorrect. Great job, everyone. Menstrual flow lasts more than 7 days. Patient uses more than 1 tampon at a time. Bleeding interferes with patient's quality of life. Yes, correct. Menstrual flow requires changing a pad or tampon more than every hour for multiple hours. Correct. And that's really the difference between patient uses more than 1 tampon at a time and this answer, that it has to be persistent. No passage of clots during menses, and patient sleeps on towels at night to protect sheets. So this would definitely be an information that you would want to elicit, but does not actually meet criteria as part of the diagnosis. Right. Oh, okay, great. I can see all of them. What 2 non-gynecological risk factors would raise index of suspicion for an underlying bleeding disorder? So easy bruising, fantastic. Family history of iron deficiency, bleeding from trivial wounds, wounds for greater than 10 minutes. And then nosebleeds again, greater than 10 minutes. And you can see below here, the correct answer is easy bruising and family history of iron deficiency anemia. Everyone was, well, the majority of people were correct. About the percentage of the general population is 1 to 2%, 20 to 30% of adolescents with heavy menstrual bleeding will go on to be diagnosed with a bleeding disorder. And according to ACOG, a bleeding disorder workup is warranted for an adolescent female with heavy menstrual bleeding for any one of the following criteria, except So a family history of a bleeding disorder definitely would warrant further workup, as would a history of anemia, as would a duration of menses greater than 7 days. Bruising 1 to 2 times per month in and of itself would not warrant further workup. A history of excessive bleeding with tooth extraction, delivery, or surgery or miscarriage would. Great.
So with that, I think we're going to move on into our case study, where again, Dr. Nancy Sakari is going to kind of share with us a specific case, and then hopefully we can kind of have an open discussion, and we'll move back to where we can hopefully see everybody's screens and talk through the case and some of the questions that you may have.
So this is a 17-year-old patient presenting to your office for heavy periods. She reports heavy bleeding since she started her period at age 13. She bleeds for about 7 to 8 days and has heavy bleeding for about 5 to 6 of those days. On her heaviest days, she's going through a tampon every 1 to 2 hours, and it's totally soaked. I really like that they specify that it's totally soaked. And she'll have flooding accidents at night unless she wears a pad in addition to the tampon. She passes clots that are about 1/4 in size on her heaviest days, and she has significant cramping and has to miss school often because of the bleeding and pain. She takes ibuprofen and using a heating pad, both of which provide some relief. In review of other bleeding challenges, she reports a history of nosebleeds when she was a child. They would often last for greater than 10 minutes. She's never been seen in urgent care setting for her nosebleeds. She denies any gum bleeding or prolonged bleeding after small wounds. Her mother and her aunt also have a history of heavy periods and have been taking iron supplements in the past. She says that she is fatigued, but busy with high school and lacrosse 4 to 5 times per week, and admits she probably doesn't get enough sleep. On confidential history, she says that she's attracted to boys, but she's never been sexually active. She's not engaged in alcohol or drug use, and she feels safe in her relationships and at home. She has mild asthma. She's never had any surgery, so we can't elicit a bleeding history from that. She only takes ibuprofen as needed and has no allergies. Her mom and maternal aunt both have heavy periods, again, have a history of needing to take iron, but no known family history of bleeding disorders, no thrombosis, no breast, colon, uterine, or ovarian cancer known in the family. Excuse me. She's a junior in high school and plays lacrosse, lives with her parents and her brother. Objectively, she has normal vita signs, but her skin does have mild pallor, an unremarkable abdominal exam, and the pelvic exam is not performed. It's not indicated. Laboratory evaluation initially shows a hemoglobin of 11 and MCV of 83, RDW of 14, ferritin of 6, and her thyroid is normal at 1.24. So Dr. Hughley is going to take us on a discussion through this case.
So I think at this point, we'd like to discuss the case. So again, I would invite those of you who feel like or want to share your video. We'd love to see your faces, but otherwise, you can certainly speak in the chat or just speak out without your video. So first, I'm curious if anybody has any clarifying questions about the case, anything that was kind of confusing or you wondered about. Any questions? So yes, it doesn't look like there's any clarifying questions. Thank you, Dr. Sakari, for leading us through that, making it pretty clear. I'm curious what everyone's initial thoughts are. Do you think that she meets criteria